So good morning, everyone. My name is Lisa Lin, and today I'll be talking to you a little bit about functional dyspepsia and gastroparesis. And I hope by the end of our talk, you're going to see that these two entities are not so black and white. So just a brief overview of my talk. For both of these conditions, I'll touch upon some of the diagnostic criteria, symptoms, etiology and pathophysiology, and treatment options. Functional dyspepsia, by Room 4 diagnostic criteria, it's characterized by at least one of the following symptoms: bothersome postprandial fullness, early satiety, epigastric pain, and epigastric burning. The patient shouldn't have evidence of structural disease that's likely to explain the symptoms. So usually, they have a normal endoscopy. Patients should fulfill criteria for the last 3 months with symptom onset of at least 6 months prior to diagnosis. So this was a study that was done looking at functional dyspepsia patients who were given a standard test meal. On the y-axis, you have the symptom score. Higher number means more symptoms. And what they saw was that among these functional dyspepsia patients, there were kind of two groups. So there are patients with symptoms that were more meal-related. And as you can see in that graph, that these patients had really significant worsening of symptoms soon after eating, within 30 minutes, especially worsening of symptoms in postprandial fullness and bloating. And then there's the other group of patients whose symptoms are more meal unrelated. So those patients will still have symptoms. Their symptoms do still get worse, a little bit worse soon after eating, but really not as significantly so as the other group of patients. And what you'll also notice with the group of patients whose symptoms are more meal unrelated, their predominant symptom is more abdominal pain rather than the fullness and bloating. So because of this, we think, now we kind of classify functional dyspepsia as there are two subtypes. So there's postprandial distress syndrome subtype, which is characterized more by the bothersome postprandial fullness and early satiety, and epigastric pain syndrome that's characterized more by the epigastric pain and burning. Other symptoms that are associated with functional dyspepsia includes postprandial nausea, upper abdominal bloating, belching, weight loss up to 5% of body weight. And I think it's important to note that persistent vomiting is really not typical for functional dyspepsia. If someone is coming to you with a lot of vomiting, you really have to think about something else. The diagnostic criteria for gastroparesis includes, certainly that patients should have symptoms that are consistent with gastroparesis. So that includes nausea, vomiting, early satiety, postprandial fullness, epigastric pain, bloating, and weight loss. And the symptoms that I've bolded here are symptoms that have been shown to be correlated more with a delayed gastric emptying. And you need to have some objective measure of delayed gastric emptying, and you need to rule out a mechanical obstruction. So whether that's via an EGD, imaging study like an upper GI study with small bowel follow-through, these are all tests that you can pursue. So as you can see from kind of the last few slides, there are, functional dyspepsia and gastroparesis, they really share a lot of similar symptoms. So abdominal pain, early satiety, bloating are very common symptoms in both functional dyspepsia and gastroparesis. And symptoms of nausea, vomiting, loss of appetite, weight loss really is more prevalent in gastroparesis when compared to functional dyspepsia. And malnutrition is really usually not present in functional dyspepsia. And, they've done studies where they looked at functional dyspepsia patients and they would apply the GCSI score, which is Gastroparesis Cardinal Symptom Index. So this is a validated scoring system that they oftentimes use in clinical trials for gastroparesis. And they saw that the GCSI score was only slightly lower in functional dyspepsia patients compared to gastroparesis patients. So again, emphasizing that, in terms of symptoms, oftentimes, both of these groups are more similarities than differences. In terms of etiologies and pathophysiologies, I'm not going to go into the nuances in too much detail here, but I think the big point that I wanted to make here is that in terms of etiologies for both of these conditions, there are a lot of varied proposed etiologies, some that are thought to be more specific for functional dyspepsia, some that are thought to be more specific for gastroparesis. In kind of that shared middle of this Venn diagram, you see that shared etiologies for both of these conditions includes medications, post-infection, and idiopathic. So in terms of pathophysiology, same concept, right? So there are some pathophysiologies that are specific for functional dyspepsia, like duodenal inflammation, altered central processing, gastric bile acid hypersensitivity. These have all been proposed mechanisms. And for gastroparesis, certainly we think there is some sort of dysmotility, such as antroduodenal dysfunction, pylospasm, gastric pacemaker dysrhythmia, but there are a lot of also shared pathophysiology. So, while we think that delayed gastric emptying is a hallmark of gastroparesis, it's important to know that up to 30% of patients with functional dyspepsia actually have delayed gastric emptying, and up to 30% of patients with functional dyspepsia have impaired fundal accommodation, and visceral hypersensitivity can exist in both conditions. I think a lot of times clinically, and as you imagine clinic patients who you've seen, I'm sure you've seen this in clinic, it's sometimes difficult to differentiate these two conditions based on symptoms because symptoms don't necessarily accurately reflect always the underlying pathophysiology or predict response to therapy. And as we have all seen, and this has been well shown in studies, is that the symptom severity does not necessarily accurately predict the extent of delay in gastric emptying. In terms of epidemiology, functional dyspepsia is really much more prevalent than gastroparesis. So if a patient comes to you in clinic with symptoms of upper abdominal pain, early satiety, nausea, bloating, no alarm symptoms, if you're a gambling person, right, they are 3 to 6 times much more likely to have functional dyspepsia than gastroparesis. In a study this is kind of addressing the natural history of these conditions. In a study where they looked at about 250 patients with functional dyspepsia with a mean follow-up time of 68 months, 17% reported symptom resolution, 38% reported symptom improvement. And we think that about a third of post-infection gastroparesis patients will note symptom improvement or resolution over time, kind of ranging from months to years and not weeks to months. Patients with gastroparesis secondary to an underlying disorder such as diabetes, scleroderma, these conditions are not going to go away, or prior gastric surgery, or they're on narcotics. Generally, these patients will have symptom improvement with treatment, but the symptoms are not going to resolve on its own. In terms of diagnostic workup, I think for both of these conditions, it's important to do a thorough history and physical. Some of the important things I think to ask about are childhood GI symptoms. That kind of gives you a sense of, okay, does this person maybe have a baseline predisposition toward visceral hypersensitivity? You want to ask them, do they have early childhood adverse events? These are all parts of the history that gives you a sense, maybe this person more likely has functional dyspepsia. It's also important to ask about potential triggers before symptom onset. So for example, if they had a traumatic life event that preceded their symptom onset, then it's much more likely that I think this person kind of pushes you toward functional dyspepsia as the diagnosis. On exam, you can listen for a succussion splash on auscultation of the stomach, which suggests more gastroparesis. Basic labs, CBC, CMP, I think for all of these patients, a lot of times they're going to have epigastric pain. It's important to note that routine lipase is not recommended in absence of known risk factors for pancreatitis. So that's not something that I usually check. Routine celiac lab is actually not recommended either, although oftentimes it is checked. When you do an upper endoscopy to rule out organic etiologies, you can do gastric biopsies to evaluate for H. pylori, duodenal biopsies if there is clinical suspicion for an inflammatory condition. So for example, celiac disease, eosinophilic gastroenteritis, which is much more rare. And Of course, in someone where you clinically suspect that there is a gastric emptying delay, you can get a gastric emptying study. You do not have to do this on everyone. If you are going to do a gastric emptying study, you can do it via scintigraphy, which is what's most often done. There are some places that do 4-hour gastric emptying studies, some places that do 2-hour gastric emptying studies. Really, the 4-hour study is the gold standard. It's thought to be more accurate. There tends to be a higher rate of false positives with 2-hour gastric emptying studies. So oftentimes, like in clinic, if I see someone who is diagnosed with gastroparesis with a 2-hour gastric emptying study, oftentimes I may want to repeat it with a 4-hour gastric emptying study instead of giving them that diagnosis for the rest of their life. Another modality that you can do is wireless motility capsule that will give you gastric emptying times and also small bowel and colon transit times. When you do these motility studies, you want to make sure that these patients are not on narcotics. And you want to try to ensure that their blood sugar is as normal as possible, because when it is elevated, greater than 180, it can cause gastric emptying delay. So going over some of the treatment options for both. For functional dyspepsia, there's really no one validated treatment approach. It's really targeted against usually the most bothersome symptom. There's unfortunately no FDA-approved medication. So the first thing, and I think this is the most important actually, is to provide patient reassurance, education, and communicating a confident and positive diagnosis. I really think that, the worst thing that you can do is to do a bunch of diagnostic testing and say at the end of it, we're not sure what you have, because that really is not good for that patient. Dietary changes such as more frequent smaller meals, avoiding high-fat foods, coffee, alcohol, smoking, avoiding NSAIDs. I think these are things that are frequently recommended to patients but really have not been studied systematically. Eradicating H. pylori has been shown to have a small but statistically significant benefit in patients with chronic dyspepsia, with a number needed to treat of about 14, and it's been shown to be a cost-effective strategy compared to long-term alternative therapies. But it's unclear that if this treatment approach, if the efficacy differs between the different functional dyspepsia subtypes, so postprandial distress syndrome subtype versus epigastric pain syndrome subtype. And if the patient is H. pylori negative or symptoms don't respond to H. pylori treatment, then acid suppression, what you'll see, is a common next step. This has been studied more extensively in functional dyspepsia, less so in gastroparesis. But generally, the trials are ranges from 2 to 8 weeks. Generally, it's been shown to have a 10 to 15% therapeutic gain over placebo in randomized controlled trials in functional dyspepsia, with a number needed to treat of about 10. This was a study that was comparing placebo versus lansoprazole. And as you can see from the chart here, lansoprazole provided a statistically significant benefit in symptoms or improvement in symptoms, specifically for epigastric pain and epigastric burning after about 4 weeks, whereas there was not the same improvement or no significant improvement in symptoms of postprandial fullness and early satiety. So it's really thought that acid suppression is not as effective in relieving symptoms of postprandial distress syndrome subtype. Fundus relaxing drugs is another treatment that has been studied in functional dyspepsia. Buspirone, as what we were talking about before, improves fundal accommodation and has shown benefit over placebo in functional dyspepsia. You can see from this chart here, I've basically highlighted in red the symptoms that where buspirone showed a statistically significant benefit in symptoms compared to placebo. So it improves symptoms of postprandial fullness, bloating, and early satiety. So usually I start 5 milligrams. You can't go up to 10, 15 to 30 minutes before a meal, up to 3 times a day. Mirtazapine is another agent that you can use. There has been some thought that mirtazapine can improve GI transit, although I would say this is not well established. It's been shown in some animal studies, but not well established. I also usually start at 15 milligrams at bedtime. You can titrate up. So these agents have really not been well studied in gastroparesis. Mirtazapine, there's been some case studies. There was a small open label study done in mostly idiopathic gastroparesis patients that did show improvement in nausea, vomiting at 2 to 4 weeks. But definitely overall for this class of drug, the data is more limited in gastroparesis. Prokinetics definitely has been studied for functional dyspepsia and gastroparesis. There was a meta-analysis of 38 studies that showed benefit over placebo in improving overall functional dyspepsia symptoms with a number needed to treat of about 7. So as you can see here in that meta-analysis, the relative risk was about 0.81, favoring prokinetics. A few caveats that I wanted to note here was that in most of those studies that were used in the meta-analysis, so a lot of these were older studies that use older prokinetics that are either no longer available on the market or not available here in the States. So if you, for example, removed the studies that included cisapride, which is no longer on the market, the number needed to treat increased from 7 to 12. And adverse events were overall similar between prokinetic drug and placebo. So the available prokinetics in the US includes metoclopramide, erythromycin, prucalopride. These have all demonstrated improvement in gastroparesis. Unfortunately, the only the only prokinetic that has an FDA approval for gastroparesis indication is metoclopramide. So a lot of these prokinetics we use off-label for gastroparesis. Antidepressants has mostly been studied in functional dyspepsia, less so in gastroparesis. So low-dose amitriptyline, same kind of dosage, starting at 10 milligrams up to 50 milligrams. Low-dose amitriptyline has shown benefit over placebo, as you can see in this chart. I think some of these graphs are a little bit off in these slides, but basically the number needed to treat was 7, which is pretty good. And what's been shown in these studies is that low-dose TCAs, particularly amitriptyline, showed more benefit in patients with symptoms of epigastric pain syndrome subtype and not so much for the patients with postprandial distress syndrome subtype. It also didn't show significant benefit in patients with delayed gastric emptying. Placebo-controlled trials with SSRI and SNRI also didn't show significant benefit and generally poor tolerance in patients with functional dyspepsia. There was like a small study that was done with nortriptyline in gastroparesis, and that didn't show benefit in those patients. So in terms of treatment for gastroparesis, again, same as functional dyspepsia, there's no one validated treatment algorithm. Generally, we start with dietary and lifestyle changes, more frequent smaller meals, avoid high-fat and high-fiber foods, wait 3 to 4 hours after a meal before lying down. Antiemetic agents we oftentimes use, and certainly prokinetics. There are some therapies that are more specific for gastroparesis, like gastric electrical stimulation, GPOM, GJ tube feeding, surgical therapy. So kind of after all of those things that I just presented, I encourage you, I think functional dyspepsia and gastroparesis is not like kind of the older classic teaching. These are not really two totally distinctive entities that exist in completely different silos. I would encourage you to think of functional dyspepsia and gastroparesis as existing on a spectrum. There are certainly patients who fall on either end of the spectrum who are very classically functional dyspepsia, maybe epigastric pain syndrome subtype, some patients who are very classic gastroparesis. But there are also a lot of patients who are going to fall somewhere along that spectrum. So for example, you can have a patient with gastroparesis with delayed gastric emptying, but they don't have much nausea and vomiting, and maybe epigastric pain is their predominant symptom. So they're a little bit on that left side of the spectrum. Or you may have a patient with functional dyspepsia with possible some gastric emptying delay who has more of those postprandial nausea type of symptoms. So treatment for both, you can certainly always start with diet and lifestyle, safe things to do. Acid suppression therapy, there is more evidence for using that in functional dyspepsia patients, especially epigastric pain syndrome subtype. But the important thing to remember is for gastroparesis patients, there is a huge overlap of GERD and gastroparesis. Like more than 50% of patients with gastroparesis will have GERD. So a lot of those patients, will be treated with acid suppression therapy, and it will help them. And I think kind of going forward beyond this, I really encourage you to, really ask the patient about what is their most bothersome GI symptom and really guiding your treatment options based on that, targeted toward that most bothersome GI symptom. So if someone has nausea, certainly there are various antiemetic agents that you can use. If they have gastric emptying delay, you can consider use of various prokinetic options. If their bothersome GI symptom is more early satiety, postprandial fullness, or nausea, you can consider use of fundus relaxing drugs such as buspirone or mirtazapine. I especially would consider use, for example, of mirtazapine if someone has a lot of unintentional weight loss, or they may have insomnia or poor appetite. I think mirtazapine can be very helpful with that. You can also consider prokinetic use in some of these patients as well. If someone has the predominant symptom of abdominal pain, then I definitely think you should consider the use of a neuromodulator, even if they have gastroparesis. So, and these are all in the class of antidepressants. Tricyclic does have the best evidence. But I think, which agent you use really is patient specific. I think a few important things to remember is that tricyclics with the anticholinergic effects can slow down GI motility, including the stomach. So for someone with, for example, gastroparesis with predominant abdominal pain, I would probably use something like a disipramine instead of amitriptyline. Or let's say, for example, if you have someone with gastroparesis, predominant abdominal pain, and if they also have the diagnosis of fibromyalgia, or you think that this person has a lot of central anxiety that is maybe worsening their visceral hypersensitivity, driving a lot of that abdominal pain, then I would consider using an SNRI such as Cymbalta, even though the evidence for that is not necessarily as strong. And again, kind of similar to what I listed on the last slide, there are some treatments that are more invasive, that are more specific to gastroparesis that I wouldn't use in functional dyspepsia patients. So overall, take-home points. I think I want to encourage you to think of these two entities as not two totally distinct entities, but think of them as existing on a spectrum, and your patients can fall somewhere along this spectrum. You can certainly start with diet, lifestyle, acid suppression therapy for both, but really kind of going forward, what's going to drive which medication, which therapy you're going to choose is asking about their most bothersome GI symptom and using your medication targeting that. And think about the possible pathophysiology that's driving their symptoms. And hopefully, my goal with this talk is I want you to feel like your toolbox for treating both of these conditions are expanded, right? I don't want you to feel limited in particular by the diagnosis alone. So thank you for your time.